Good morning. My name is Kathryn Schlosser. I'm going to be discussing predictors of respiratory failure after open ventral hernia repair. These are our disclosures. Studies of national databases have estimated the rate of respiratory failure after major non-cardiac surgery at 3.4%. In various studies, respiratory failure has been associated with ASA score, emergency surgery, CHF, tobacco use, pulmonary function, patient age, obesity, OSA, sex, lung disease, and the type of surgery performed. The rate of respiratory failure after abdominal wall reconstruction has been reported as high as 16 to 20%. Challenges unique to the ventral hernia population include an obese population of patients with a high baseline intra-abdominal pressure and the increased intra-abdominal pressure associated with the reduction of visceral contents into the abdominal cavity. Previous studies have demonstrated that a change in plateau pressure of over 6 millimeters mercury after fascial closure is associated with significantly higher respiratory failure after surgery. The goal of the study was to assess predictors of respiratory failure after open ventral hernia repair. For this purpose, we queried our prospective single-institution hernia-specific database from 2007 to 2018. We then performed three-dimensional CT volumetrics on the patients who had a CT scan within a year of their open ventral hernia repair. For the purposes of this study, we defined respiratory insufficiency as a new persistent oxygen requirement requiring greater than 1 day of supportive therapy such as CPAP or BiPAP, or reintubation with mechanical ventilation. Based on prior literature, we performed CT volumetric analysis from the top of the diaphragm to the pubic symphysis. Here you can see this sort of analysis with subcutaneous volume in blue. This patient has 9.8 liters of subcutaneous fat. Total visceral volume is 5.7 liters in this patient, and hernia volume is 1.4 liters in orange. We identified 1,178 patients with available CT scans for analysis. Nearly 60% were women, and many were comorbid, including diabetes, history of smoking, COPD, and 8.5% had a history of a previous MRSA infection. Mean hernia volume was almost 1 liter, intra-abdominal volume 4 liters, and subcutaneous fat volume 6.8 liters. Mean defect area was 155 centimeters squared. 26% of patients had contaminated cases, with over half of the contaminated cases having a pre-existing mesh infection or fistula at the time of repair. 48% of patients underwent component separation, and 94% had mesh placed at the time of repair. Outcomes after surgery included a 30-day readmission rate of 13%, with a wound complication rate of 33%. When we looked at respiratory insufficiency, the total rate was 8.3%, with 4% of patients requiring sustained respiratory support and 4.3% requiring reintubation. When we compared patients who developed respiratory insufficiency to those who did not, we found that they were significantly more comorbid. They were older with higher BMI and nearly double the rates of diabetes, asthma, COPD, and history of MRSA. Patients who developed respiratory insufficiency also had larger hernia defects, larger hernia volume, and nearly double the ratio of hernia to intra-abdominal volume. When we looked at the operative experience, patients who developed respiratory insufficiency were more likely to have undergone component separation, were less likely to have achieved fascial closure at their time of operation, and had a significantly higher rate of wound contamination. Given the significant differences in outcomes after clean or contaminated open ventral hernia repair, we examined these separately. Patients who developed respiratory insufficiency in clean cases had more than double the length of stay, with higher rates of all measured adverse outcomes, including wound complications, reoperation, recurrence, and readmission. In the 26% of cases which were contaminated, patients who developed respiratory insufficiency had longer length of stay, but no statistical difference in other outcomes. Given the high degree of overlap between markers of hernia dimensions and fat distribution, we performed a statistical technique called principal component analysis. This allows us to combine variables with high correlation, such as BMI and subcutaneous fat, into single composite variables which we can use for further analysis. Each principal component is a combined variable, which is a surrogate for closely related variables. The loadings across the bottom are called eigenvectors, and these signify the magnitude of the association of the new variable with variability in the data. For example, the principal component titled hernia PC accounts for 38% of variance in the data and consists primarily of hernia volume, defect size, and the ratio of hernia volume to intra-abdominal volume. The principal component variable titled EAV for extra-abdominal volume consists primarily of BMI and subcutaneous fat. And finally, the component variable IAV, intra-abdominal volume, consists primarily of intra-abdominal volume. We then used these constructed variables to perform a multivariate analysis, controlling for the multiple differences we found between these populations. When examining outcomes after open ventral hernia repair, the development of respiratory insufficiency was associated with the principal component variable hernia PC, which, if you recall, reflects hernia dimensions, including defect area, volume, and the ratio of hernia volume to intra-abdominal volume. Extra-abdominal volume component, or principal component, reflects primarily subcutaneous fat and BMI, and was also associated with respiratory insufficiency. Patients with a history of COPD had 4 times the rate of developing respiratory insufficiency after surgery, and diabetes was also related with this outcome. Hernia PC was also associated with readmission, wound complication, and reoperation, and extra-abdominal volume, or subcutaneous fat and BMI, was associated with readmission and wound complication. When we looked at intraoperative intervention, we found that contamination, paniculectomy, component separation, and fascial defect closure were not associated with respiratory insufficiency. We did find that contamination was associated with other adverse outcomes, such as readmission, wound complication, recurrence, and reoperation. And we found that fascial defect closure was protective for recurrence and reoperation. To make sense of this, we separated patients into tertiles based on the predicted likelihood of respiratory failure based on our multivariate analysis. Patients in the highest tertile had greater than an 8.3% risk of developing respiratory insufficiency. These patients had a BMI of about 38, age 64 or over. 57% were diabetic compared to 30% of the baseline population. 28% had asthma, and 19% had COPD. When we looked at the dimensions of their hernia and the distribution of their fat, we found that their average defect area was 250 centimeters squared, with a hernia volume of over 2 liters. Importantly, the ratio of their hernia to intra-abdominal volume was over 50%. This constitutes well over loss of domain based on multiple definitions. In conclusion, patients who develop respiratory insufficiency at baseline are more comorbid with higher BMI, greater age, and higher rates of diabetes, asthma, COPD, and MRSA. They have different hernia characteristics, with larger hernias when we measure area, volume, and larger ratio of hernia volume to intra-abdominal volume. We did not find that there was a significant difference with subcutaneous volumes. They also have a different operative experience. They have a higher rate of contamination, less fascial closure, more component separation, and with all of these, a longer operative time. Finally, on multivariate analysis, we found that respiratory insufficiency was associated primarily with hernia factors, a little bit with extra-abdominal volume, as represented by subcutaneous fat and BMI, with COPD, and with diabetes. Knowing these factors, when we approach a patient who's going to be undergoing open ventral hernia repair, we have the tools now to flag these patients for preoperative respiratory preparation and prehabilitation, and we are more aware, coming out of surgery, of the patients who might develop respiratory insufficiency in the days after intervention. Thank you very much. I'll take any questions.
Thank you very much for a very interesting analysis. Are there any questions from the floor? Maybe we can start with the conclusions, because the data that you have analyzed provide interesting feedback. So what kind of different practices have you implemented? Do you prepare these patients better in a respiratory way, or do you include it in your conversation with the patient whether he or she should undergo surgery? How do you do that?
So one of the things we're looking at now is what when we ask for respiratory clearance, in the same way we ask for cardiac clearance, what does that actually involve? And are we doing our due diligence in that context? And so in this setting, when we're preparing someone, we are already asking for glycemic control, for tobacco cessation, and often for weight loss, and whether this is going to be part of their prehabilitation if they're at high risk for postoperative respiratory failure, that's what we're moving towards. And that's going to be in collaboration with anesthesia, with their pulmonary physicians, and with the rest of the team.
Thank you. Question? Yes, please.
I'm in Rochester, Minnesota. Very nice presentation. Thank you very much. You measured a number of components, and as I was watching you, maybe I didn't hear, did you also measure muscle density or sarcopenia? Does that relate in any way to respiratory failure, as the respiratory muscle strength may be one component that affects your outcome?
So we've actually used the same data and measured sarcopenia as measured by the psoas area in the same patient population. In this data, no matter which way I sliced it, I was unable to find an association of sarcopenia with respiratory failure or other adverse outcomes after surgery. And so that doesn't mean it's not there. It means that we weren't able to find that association.
Okay.
Go ahead.
So two other things that have been tried that don't work, preoperative pneumoperitoneum, in terms of changing your loss of domain, pulmonary training. I mean, again, it's not just telling someone, yeah, you're going to have problems after surgery. We know about this, tobacco cessation. What else can you do to help these people? I mean, I think it's, you've got a great study. How are we going to change our practice?
So there's two aspects of that which you've addressed, and I have seen some literature that actually supports both of those things.
Yeah.
So preoperative abdominal wall compliance, that's what people are getting at with preoperative pneumoperitoneum. There have been a couple studies which have looked at the size of the hernia as well as the size of the intra-abdominal contents when you do a preoperative pneumoperitoneum, and that is theorized to potentially increase the compliance of the abdominal wall. One thing that's thrown around a lot we currently don't have enough data on is preoperative botulinum toxin injections,
right,
which is currently being used to help reapproximate the abdominal wall in patients who have loss of domain with retraction of the lateral abdominal musculature. Some of the most promising stuff that I have seen in my literature review for this has been people who have done pretty aggressive preoperative prehabilitation, and they have found that if you have patients with large hernias and you are working on their pulmonary function with respiratory exercises in the same way we do after surgery, that benefit continues even after you reduce a large hernia sac into the abdominal contents.
Okay. Thank you very much.
Thank you very much. Great job.
Thank you for your time.